Hello, my name is Vicki Collie-Akers, and I am Associate Director of Health Promotion Research at the KU Workgroup for Community Health and Development. In addition, I am a staff liaison to the Academic Health Department that has been established between the University of Kansas and the Lawrence Douglas County Health Department. During this presentation, I will be providing a description of our work with the Lawrence Douglas County Health Department as we have collaboratively worked to implement the Community Toolbox Building a Healthy Community model. Our partnership with the Health Department began in 2011 when Health Department leadership reached out to our research center to embark on a community health assessment and planning process. The process began by convening a steering committee representing several sectors of the community. These included our team at KU, a collaborative partnership called the Douglas County Community Health Improvement Partnership, the United Way of Douglas County, the Heartland Community Health Center, the Douglas County Community Foundation, Lawrence Memorial Hospital, and the Health Department. The steering committee worked by meeting every other week between October 2011 and May 2012. The committee worked to create plans for collecting data, reviewed the process, supported data collection, and reviewed findings. The steering committee settled on using a mixed methods approach, that is, one that uses both qualitative and quantitative methodologies. These methods included a concern survey that asked community members about their perceptions of the relative strengths and problems in the community. Focus groups and key informant interviews were used to better understand conditions that have an impact on health, as well as the assets that contribute to a healthy community. Small area analysis of hospital emergency department utilization for preventable health issues were mapped by users' residential addresses to understand if there are concentrations of health issues by neighborhood. Data from other sources, such as the Behavioral Risk Factor Surveillance System, the Census Bureau, the Kansas Department of Health and Environment, and the Bureau of Labor Statistics, were collected to better understand health status and health behavior. A local public health system assessment was conducted using the National Public Health Performance Standards Program to assess the performance of the local public health system relative to the ideal performance of public health systems. Lastly, a photo voice project was conducted with high school students to obtain youth perspectives about community health issues. Students were provided with a camera and asked to take pictures of community conditions that contributed to health and conditions that detracted from health. Across all data collection efforts, more than 1,500 community members were engaged at least once. The resulting data resulted in a number of different types of information that were presented in a number of different ways. This slide contains a number of different types of data that were presented to the community. These include, at the upper left-hand corner, you can see a table of some of the community health indicators that were collected. More than 40 indicators were collected, for which we provided the most recent 3 years of data for Douglas County, as well as the related Healthy People 2020 objective. Colors were used to indicate if the Douglas County values were approaching achievement of the Healthy People 2020 objective or were far from achieving the objective. In the upper middle, you can see a list of the relative problems that were identified using the concern survey methodology of looking at issues that were reported as important to the community, but that the community is not doing well at addressing. The upper left corner contains a picture that a youth participating in the Photo Voice project took in response to the question of what conditions detract from health. On the bottom row, in the left-hand corner, is an example of small area analysis that had resulted from the effort. The graphic uses colors ranging from blue to red. The red reflects higher concentration of utilization of the emergency department for dental issues. In the lower middle, you can see a quote from a community member who participated in focus groups or key informant interviews that describes some of the conditions in the community that contribute to inequity. Lastly, on the lower right-hand corner is a chart resulting from the local public health systems assessment. This chart describes the Douglas County public health system. The chart contains the 10 essential public health services and quantifies the performance of public health systems on a scale of 0, as in no performance, to 100, as in ideal performance. The information from these 7 data collection methods were used to identify convergent issues, that is, those issues in which 2 or more methodologies suggested that a topic was a prospective public health priority. In total, 13 issues were identified. The total findings from all methods were presented to the community in a number of forums across the county. A series of meetings with community members resulted in narrowing the 13 issues to 5 priority community health issues that included access to healthy foods, access to health services, poverty or too few jobs, mental health and access to mental health services, and lack of physical activity. It was decided that these were the 5 issues that would move forward to community health planning efforts. To undertake the community health planning effort, community partners were engaged to lead work groups consisting of community members and partners that would be assembled for each of the given 5 priority areas. These included Kansas State Research and Extension, which led the Access to Healthy Food work group. The Douglas County Community Foundation led the Physical Activity work group. Lawrence Memorial Hospital led the Access to Health Services work group. The Burt Nash Community Mental Health Center led the Mental Health work group. And lastly, the Poverty and Jobs work group was led by the United Way of Douglas County. After the lead groups had been identified and membership of the work groups assembled, planning began in earnest. The steering committee and work group leads developed the vision and mission that reflected the overall plan. The vision that was developed was a healthier Douglas County, and the mission was written as to collectively improve health for all through environmental and policy change that is responsive and accountable to the community. After that, the KU work group worked with work group leads to walk through a 6-phase planning process. This included framing the issue with clarity as a problem or goal, examining the root causes that create the priority health issues, development of SMART+C objectives that would provide measurable outcomes for the community health plan. This led to the identification, development, and prioritization of strategies, that is, policy, system, and environmental changes to pursue as a community. All of this information was compiled into a logic model for each group that was reviewed by those engaged in the planning effort. Lastly, the work groups worked to create modest plans for implementation. The result was a comprehensive community health plan that contains goals, measurable objectives, strategies, and selected policy, system, and environmental changes for each of the priority issues. The plan was adopted by the Steering Committee and Health Board on April 23, 2013, and at that time, the effort began to assure implementation of the community health plan. Staff from the community health team at the Lawrence Douglas County Health Department have worked diligently to bring community partners to the table for implementation. One of the early wins was having every municipal and county government adopt the plan as its guiding plan for improving community health. Additionally, it was adopted by the Live Well Lawrence Coalition as its strategic plan, and other organizations have worked to integrate part of the plan in their own work. Staff have been working with individual partners as well as partnerships to assure implementation. Concurrent with the ACT phase of the model, our team worked with the Lawrence Douglas County Health Department to implement several activities to assure ongoing evaluation. To do this, we created a data collection system that integrates documentation of activities and accomplishments implemented to make progress on the implementation of the community health plan, a place to store data regarding longer-term objectives outlined in the plan, and real-time access to data and related graphs that communicate information about the plan. The system was opened up to all community partners to contribute information to better assemble evidence in response to 2 driving evaluation questions. To what extent are community partners contributing to implementation of the community health plan? And to what extent is the community health plan being implemented? To date, more than 20 organizations have been trained to document their efforts at implementing the community health plan in the data collection system. The system does produce graphs that can be used by community partners to make sense of the progress toward implementation of the community health plan. Here are 2 examples of these graphs. The graph on the left side of the page presents information about how all of the activities documented by partners are distributed by goal area to allow partners to ask about whether all goal areas are being addressed and to what extent they are being addressed. The graph on the left displays information about the longer-term outcomes of the initiative. One of the longer-term outcomes is the proportion of Douglas County adults who are obese. This information is presented to partners to assess if their efforts are having an impact on the community. Lastly, I will mention the effort to assure that sustainability is part of the work to implement the community health plan. It should be noted that several strategies are being implemented concurrently. First, the group has purposefully focused on policy, system, and environmental changes that have a more inherent likelihood of being sustained by virtue of being somewhat permanent in nature. Second, when efforts were programmatic or not permanent, partners were encouraged to consider sustainability as part of implementation. Third, staff and partners do spend considerable time working to develop the capacity of partners as time goes on, so that the likelihood of an enhanced capacity will increase sustainability. Lastly, the partners view assessment, planning, implementation, and evaluation as iterative, so that while a single program might not be sustained, that information would be known and considered as efforts move forward. In closing, I would like to invite you to learn more about this effort. You are welcome to go to ldchealth.org, healthydouglascounty.org, or communityhealth.ku.edu to learn more, or you can email me at vcollie@ku.edu. Thank you.